decrease in fibrosis rather than other endobariatric, even with weight loss, have not shown that. So is it that glucagon receptor which is responsible for the fibrosis? Adding that would help with endobariatrics.
Yeah, I think it is the future where you can combine low dose, 4 milligram is expensive. You may have 0.1 milligram of survodutide along with endobariatric. So I think the combination of, volume of the stomach being reduced, whichever way, plus GLP-1, agonist by fasting or by whichever method is a good idea. Fibrosis reduction is by TGF beta, we do not know, but most likely it is the GIP and not the GLP-1.
Thank you. Thank you very much. Thank you. Big round of applause. One of the best sessions of the time.
Never give a talk. I also have a picture to look like a surgeon. I never could comment on you. Thank you. Thank you for this.
Thank you. So after such a, it's very difficult to keep everybody bound to the hall after such a captivating talk from you. But we have a very interesting session. I would invite at this stage and welcome Haris Khwaja, who is the president of the International Bariatric Club globally. And it's an honor to invite Silvana to start the IBC session. We have some very interesting things coming up.
Yes, thank you. Thank you, Mohit. And Haris, we can see you. Welcome. Welcome to Indoor. We cannot hear you, though. And Sai.
Thank you. Can you hear me now, Silvana?
Thank you so much for waking up early or staying up late. I don't know what time is it in Thailand now. Haris, we still cannot hear you.
Can you hear me now?
While we are connecting and fixing, no, I still cannot hear you.
Hi, Silvana. Nice to see you.
Let's see what we can do, but we are delighted to have the 61st IBC Symposium here in Indore during the first B1 meeting. And we are delighted to have you, Haris, with this session.
Okay.
Oh.
Can you hear me?
Yes. Yes.
You can hear me now?
Yes, I can hear you.
Excellent. So thank you, Silvana, and thank you, Mohit and Christine, for this very kind invitation. Firstly, congratulations to ERCAD India. Congratulations to the first Bariatric Endoscopy World Association Organizing Committee for an outstanding Congress, which I've been following on LinkedIn and various social media platforms. It was about time that Bariatric Endoscopy has its own World Congress, and congratulations for that achievement. Secondly, I'd like to thank all the faculty taking part today in the 61st IBC Symposium, the 12th in the Asia-Pacific region, and the first at BIVA. And it gives me a great honor to welcome Professor Sai Jerapinho, who's going to chair this keynote session. And I'll hand over to Sai. The theme of this particular symposium, as you probably realize from the program, is all about the future, because surgeries and endoscopy procedures we spoke about a couple of years ago are now prime time. And what we're really interested in is what is going to happen in the next 15 years. So I pass on to you, Sai, to start this symposium.
There you go. Can everyone hear me okay? Wonderful. Thank you so much, Haris. It's such a great honor to be here with you. And I just want to echo what Haris said. Congratulations to Silvana, Christine, Manuel, and Mohit. Big success. And I'm so sad. I apologize. I could not be there in person. I wish I were there with all of you. So for our first session, I'm very honored to be introducing our two wonderful moderators who need no introduction. The first one is Professor Eduardo Greco from Brazil, and also Dr. Amit Madeo from India. And both of them are going to be introducing our first speaker, my dear colleague and friend, Roman. I think I saw Roman getting up to the stage. So it's my great honor to be introducing the first speaker. He also needs no introduction, Roman Churros, and he is going to be giving a lecture on augmenting weight loss after sleeve gastrectomy through endoluminal magnetic revisional surgery, the magic of magnets. The floor is yours, Roman.
Okay, do you hear me? Sai, Harris, can you hear me? Okay, thanks. Thank you so much for IBC. Thank you, Harris, for giving me the opportunity again to be here. Thank you, Sai, for the kind presentation. And also to everyone that it's here, all the members for BIWA, everyone from IRCAD India, Mohit, Manuel. It's such a pleasure for me to be here. So I'm going to try to be a little bit like fast because we're going behind schedule. So let's talk a little bit about like what it is deep magnetic anastomosis. So those are my disclosures. First of all, I want to thank also my team because thanks to my team, we're possible to be doing that amazing things. So we know that endoscopy, it is a good technology. We like a lot of things are happening. We've been like talking about a lot of bariatric endoscopy procedures, but the real reality is that the gold standard for it is a surgical approach when we have obese patients. Sleeve gastrectomy, it's probably one of the highest volume number of interventions, but those patients after a while, if they regain weight, we have data that on some revisionals that after 5 years, more than 30-40% of the patients, they regain their weight. The options that they do have, it is conversion. And that we know that they increase the risk and it's very a little bit more challenging. So it is not an accessible option. So it has sense to be thinking about like bariatric endoscopy as an approach. But what are the limitations that we have right now as bariatric endoscopy? We are just doing restrictive procedures. There's not yet any malabsorptive procedure that could add that component to that. It would increase the weight loss. So that's why we took place in our institution for a study, which is the SNAP procedure, which is a hybrid approach where we do a placement of a octagonal magnet on the bulb and then at 3 meters from the bulb. So the inclusion criteria were patients that they had the sleeve gastrectomy more than 12 months ago with a regain of 10% of their body weight loss, or they regain more than 10 kg after the intervention. And you can see here the laparoscopic approach. So the first thing that when we are going to go for those cases, the surgeon is going to prepare the area. It's going to do an enterotomy. Then through the enterotomy, they're going to advance the magnet with the tool. It doesn't require any extra or special tools for doing the procedure, which is kind of something interesting for this kind of intervention. And then by fluoroscopy, we're going to check that these magnets, the octagonal magnets, they are self-assembling. Once the magnet is on place, we're going to go for the endoscopic placement. So we're going to go to the bulb, we're going to deploy the magnet. You see how the magnet is coming out. And once the magnet is outside, we're going to add it to the cup that we have. And we're going to face usually anterior wall of the bulb. So then by transillumination, we're going to identify the position, and the surgeon, the only thing that he has to do is approach the magnet, and we have the assembling part. After that, we're going to do a fluoroscopy to check that everything it's the way it should be. And on our practice, 27 cases done, we had no problems with any of the anastomosis. It went well, everything. You can see here different images. Thanks to Manuel, he also shared with me some of the images. And here we can see also how it looks immediately, just right after we have put the magnet, how the mucosa changed color or because of the pressure. So that's very interesting. As I said, the fluoroscopy to check that the couple is made, and let's see what it looks like after 3 months after the intervention. I think that that's kind of like very, very interesting this anastomosis. It's very nice. Very nice. We don't identify sutures, and it's as I said, on this 27 cases that we did, two cases we removed the magnets endoscopically. One on upper endoscopy, which it was removed no problem, and another one lower endoscopy, which it was removed no problem. So also we can remove them endoscopically, which is also interesting. Some other images about how it looks like the anastomosis, and let's talk about results. So the average of weight loss of patients got after the intervention, it was around 33.7% of total body weight loss. Those patients, they regain weight till around 15% on our selection, 15% of the body weight loss. And 9 months after the placement of the magnets, we almost reached the nadir that they had previously. So it's pretty good. And I think that another concept that is important, those patients, they had a history of the previous weight regain. So it's complex patient. It's not a primary result. So getting those results, those data, which is around like 70% of total body weight loss on a revisional, it's pretty high compared to what we do have with the bariatric restrictive approach, which is around like 12-30%. We had no severe adverse events related to the device. So it's very safe device, the placement. And that was recently this summer published our data. But this thing is moving forward. The one that we used in our Unity was the first generation. We were the first ones trying it, so they gave us only the first generation. Then it came Mohit and Manuel, that they're a little bit luckier than us. They used the second generation one, the Flexagon one, also a nicer, stronger magnet. You can see here, but the mechanism, the way of placement, everything, it's exactly the same. So we go to the same area, the deployment of the magnet is exactly the same. I'm gonna try to advance a little bit the video so you can see how it looked like. And then by translumination, we're gonna try to, okay, it's not moving forward, sorry. And by translumination, anyway, by translumination, we identify the area where we're gonna put. But then there's another evolution, and it's this autolock. Because one of the things that we got when we were doing the procedure, the surgeons, they were saying, but you're doing an enterotomy. An enterotomy, it's very risky. You're gonna, might have leakage because you're gonna use sutures for something that is a magnetic anastomosis. So it was kind of like, and there's this autolog, which then we jumped to Orlando with Manuel, and they had the luck to use it. And how does it work? That's a very smart idea. So when we place the enterotomy, in the place of the enterotomy, we're gonna have like a round, like a Spaxus or plastic one, and then we're gonna have the magnet around it, and we're gonna assemble both of them with the plastic inside. So it's gonna be a automatic and immediate anastomosis, and it's going to be effective immediate. So we are not expecting that it's going to affect the results, but that it's just right after the intervention, you have this going effective. In our case, we had to wait around 7 to 10 days to start having the diversion working. In this case, it's immediate. And another thing that is interesting, there was this publication at Nature that was comparing about suturing versus magnetic anastomosis. And well, you see here how is the difference about like granulation, about the collagen. So it's like kind of reinforcing the concept of doing magnetic anastomosis. And then I think that always an image is much better than a lot of words. You see on the left side, suture. You see on the right side, the magnetic anastomosis. I think that we all over here agree which one it looks better. And that's what we're seeing with the evolution. And then there's another thing more. We're not just doing it laparoscopic and endoscopy approach. You can do it also robotic approach. So it's kind of like going farther and adapting more. But the thing is that what we're seeing is that the magnetic anastomosis, it's a real good tool. And also we know that the approach that we're doing working in the bulb and the ileum, it's a perfect approach for doing management of weight regain after a sleeve gastrectomy. But the thing is that this coming more and more ways of having the device more on what we are today. So as a conclusions, I would say like this, the duodenal ileum diversion, it is an effective procedure. Obviously, it is something we have like about 100 cases in the world. We need more data. That's why they are running, actually right now it's running the FDA trial in the United States. Manuel can talk about it later if it's necessary because he is part of the study. But this combination of bariatric endoscopy with surgery, I think that that's kind of like a story of a real partnership. We have to work together, and that's for me, that's kind of had this romantic and poetic definition that the two specialties we're working together with for the benefit of our patients. Thank you so much.
Thank you. Thank you, Roman. Thank you very much. Thank you, Harris, for everybody here. Roman, we have stay here just a second. We are really happy Mohit and Galvão would provide for us the magnet session. We could see in live the procedure. And what do you think about the most benefits between this anastomosis or a regular anastomosis? And then I don't know if there is any question from the audience.
I'm not a surgeon, so I'm not doing anastomosis. But what I see is that it's fast, very fast. And then when we do the revisional, it looks very anatomically, it looks very perfect.
I think best for fistulas, leaks, maybe.
I think that we can, I mean, we have experience on endoscopy. We have experience of using also magnets, for example, for treating stenosis. And then we can place one magnet on one side, one magnet on the other side, and then they can like, it help us for the stenosis. So I think it's something that we still like, it's been there for a while, but the more engineering are involved on adapting it to be used by endoscopy, it's a perfect tool.
Okay.
Yeah, that's a very nice talk. I have only one concern. Patients with obesity, they have very bad bacteria. And we know that in the ileum, they move out from colon to the ileum. Now you're joining it to the duodenum. Do you have any data or concerns of migration of these bacteria?
It is something expectable and something that we actually, on the 27 patients that we have a couple of patients that we had to do like a long and repeat doses of antibiotic. But we are not excluding the regular pathway, so it's a diversion. So it's kind of a little bit like the wave it's responding. It's a little bit more different than if it was like a SADIS or something like that. But absolutely, I agree with you. That's something that is there, and we need to learn more to know how to deal with it.
Thank you very much, Roman. So for the next lecture, I will ask you, thank you very much. Professor, my dear friend, Professor Manuel Galvão.
Just put it out.
To the next lecture. Thank you.
Oh.
Okay. So may I?
Please.
So that's as usual, my friend Harris give us very challenging talks. And this one, you can imagine how it was. Endoscopic delivery of GLP-1 analogs. Is that too good to be true? Is that possible? Oh my. So that's where I work with in Orlando. I'm proudly work here as well as the director of bariatric endoscopy with my friend Mohit Bandari in this excellent team. Those are my conflict of interest. I offer you to judge if this presentation going to be commercial or not. I hope you can judge. And that's combination therapy, the future already mentioned of anything that treats chronic disease. And in terms of endobariatrics, what you have to offer nowadays, 2024, we have interventions on the stomach, space occupying device. We have the remodeling of the stomach by means of suturing of or applications. We have some adventures, didn't work. And as the modern metabolic surgery, we have interventions on the bowel. So metabolic surgery works with interventions in the stomach and in the bowel. That said, the interventions on the stomach we have right now, they're all in clinical use. Interventions on the bowel, they're still experimental for us. And the game is 10. Welcome to the 10 game. 10% total body weight loss. It leads to 90% amelioration or resolution of the comorbidities associated obesity. So that goal. It was 5, now it's 10. And it's changing. So who are the players? The new medicines, bariatric endoscopy, and the best way to treat severe obesity, that is surgery. So getting to that players that they were not there before, but they are. And the 10 is not more 10, it's 15. It is getting to 20. They are getting there. Don't fight them, embrace them. You fight them, you lose. You embrace it, you win. But it's not all the heaven. We have problems. I don't want solution, I want problems. What is the problem? Cost and availability. And real data show us that half of those patients, they drop. Lots of reasons. It's a chronic disease, patient's compliance, price, availability, and also as a chronic disease, is 2 ways to see that. Oh, you stop the drugs, you regain all the weight. Yes, but you have to take the drugs, the chronic disease. That happens in chronic disease. You take the drug and we gain weight. So these are the issues on that. And solutions. Dr. Harris gave us the solution to deliver GLP-1 by endoscopy. And I asked ChatGPT, my friend, what we can do. And he gave me this picture. Okay. So suppose we can have this. Imagine we can have this. What's going to be the advantage? This will be a target deliver directly on the pancreas. So reduces systemic effects, potentially, enhance absorption and potency, improved patient compliance because they're going to be injected. That's what they're going to do. They're going to refuse once they accept it. This advantage can be a little bit invasive. You're going to have to do endoscopic ultrasound or something like that. How much time the patient needs on that to do? The cost, wow, that could be good. And you need a special trained doctor to do that, and if the patient can accept it or not. And those concepts, they look like very out of the woods. Really? Published in Diabetes. The whole resurfacing history is that something in the duodenum that the healthy population has a different duodenal mucosa than the diabetic population or the metabolic impaired population. That if you touch it, and you can see here the functional mucosa, the beta cell hyperplasia, and the diabetic hypersecretion, the dysfunction of secretions, and beta cell failure. And as was mentioned before, our seminal work on duodenal mucosa resurfacing with the first model that we lift the mucosa and with thermal ablation, 87 degrees for 10 seconds from the papilla up to the triangle, we intended to do that. Results were shown. There was confusing factor, but at the end, it looks like now, my dear friend, we have thermal, we have electroporation, electrical pulse, we have cryo, we have vapor. Something is there. It's a golden rush. I'm talking about $200 million already invested in research on that. And what you think that I was just getting to my mind and explaining to you is here. They actually are working on target gene therapy to inject GLP-1 in the pancreas. So the same company that did the first mucosal intervention, they already have this. They have this intervention on special rat population. And you can see here that they get with one direct injection and compare with GLP-1 injection, I think, from regular intervals. And they compare that, and they see here, and you can see the fasting glucose get way better. The plasma insulin get higher, and the body weight decrease. Just look at the red. See, it is there. But Manuel, it's too far away. Okay, those are the results on this special, beautiful mouse. Decrease the glucose again, food intake decrease, glucose tolerance, and the injected thing stays in the pancreas, so stays there. What can I tell you? That the company just get approval to do the first patient, but it's coming. So it's not that completely surreal or unreal, my dear friend Harris. It is there. And again, we're still working a lot with the dynamic color surface and electrical pulse. This is one we are participating now to keep the patients. Look at this. One ablation in patients, they are removing the GLP-1 to avoid them to regain weight. So those things are there, and those are the concepts possible with the impossible question of Dr. Harris Kawaja. Thank you very much for this challenge. Thank you very much for watching us.
Thank you. Thank you a lot, Professor Galvão. Of course, this is going to be the future, yes, Galvão? And you think this could be combined with ESG or a simple balloon? What do you think about combining therapies?
I'm a big fan. And our research is showing that I'm calling that the bariatric endoscopy plus, balloon plus, ESG plus. So ESG, I like it more, or gastric remodeling, because it's more versatile. We can add drugs, or we combine with bowel interventions on the bowel, resurfacing, attaching a bowel anastomosis with magnets. So that's, I think, that in the same direction that the endovascular on the pass get and took over as a mainstream compared with open heart surgery. I don't see a different future. By the way, endovascular only works with drugs. Gonna be us with drugs. So believe.
Thank you. Thank you very much. So keep going. I will invite Professor Sigal Fishman to join us and give in the next lecture, please.
Can I put it on one screen only? Oh, that's fine. Thank you for having me again. And today it's actually almost like a continuation for my talk from yesterday. Before I start, from the surgeons here, how many do one anastomosis gastric bypass? How many practice? Just, do you have biliary reflux problem with your patients? Sometimes a lot. And you have? I'm talking about one anastomosis, the gastric bypass. Okay. That's fine, I do it again. So as I told you yesterday, the one anastomosis gastric bypass, because it's more simple to perform, became the third most popular operation, bariatric operation. As you can see, it has a long pouch in order to prevent the biliary reflux, and it has a large anastomosis, because the point behind this surgery is less restrictive and more malabsorptive. Because of that, there is large anastomosis. We don't need the restriction. However, so the advantage, it's significant. There is a better weight loss, shorter procedure time, and low rate of early complication. However, the complication of one anastomosis gastric bypass, because it's more malabsorptive, high rate of nutritional deficiency, steatorrhea, marginal ulcer, gastroesophageal reflux because the angle of his was changed and there is a big pouch to produce acid, and biliary reflux. Maybe not the surgeon meet the patient with these really bothering or painful symptoms. They came to us, to the gastroenterology. We give PPI, it's not help, and then we understand it's a biliary reflux. We cannot challenge it with the regular medication we have. So this is really a unique complication of the one anastomosis gastric bypass. I don't call it mini because it's not mini for the patient, it's mini for the surgeon. It's really very dramatic operation. And the incidence of bile reflux reported between different reports between 1% almost to 70%. There is no unify among the reports. The risk factor for Barrett when you have biliary reflux is 1.4%. And of course, there is all the concern for adenocarcinoma, like we see after the bile rot. So because of that, biliary reflux is a major problem in one anastomosis gastric bypass. To diagnose it, it's pretty much difficult. Predominantly, we do it on clinical base. We give the patient PPI, and if it doesn't help, we know probably it's biliary reflux. And also, when you talk to the patient, there's very typical symptoms. It's in the middle of the night, they wake up with burning, and they they vomit a yellow material. So this is really specific for symptoms for biliary reflux. Objective tools like Bilitech 2000 that identify the bile is not available, and pH monitoring has a limited value because we want to see reflux of a high pH, basic pH, but it doesn't work too good. This is the way it looks. You can see the pouch full with bile. You can see the anastomosis, and this is how it's seen in NBI. But a lot of time, you see the pouch full of bile. So what is the treatment? The medical treatment is not very effective to bile reflux. And the definitive treatment is conversion to Roux-en-Y gastric bypass. Almost between 1 and 12% and 11% of the conversion to Roux-en-Y gastric bypass from mini gastric bypass is bile reflux. Another tip that we learned that if the patient had GERD, preemptive GERD, it's significant associated with conversion to Roux-en-Y gastric bypass. So when a patient before bariatric surgery come to consult me and he tell me that he has reflux, I recommend him to go to the traditional gastric bypass, not to mini gastric bypass, and of course, not to sleeve. So what about, we thought that maybe if there is reflux of bile through the anastomosis, the wide anastomosis, maybe we can reduce it. And by that, we prevent the bile reflux. We know TORE for weight recidivism, like we saw yesterday. It's good for dumping syndrome, and we have different pattern. I won't show you the movie we saw yesterday because it's just the same. I just remind that we prefer this one, per string, argon per string, because this type of suturing enable the scar to heal in a good way. And after that, we reduce the size of the pouch, and also by doing that, we reduce the pressure from the anastomosis. So here how we do it. Again, argon, very generously we give the argon, 360%, 360% per string. We do overstitch on the balloon to control the size. We do another U, and this is how beautifully it looks after 6 months. We don't see the movie, we saw it yesterday. So we published already our local experience because I don't think that there is other publication about this issue yet. We have 12 patients post one anastomosis gastric bypass. We initially treated them with high dose PPI for 8 weeks. If it didn't work, we assumed that they have bile reflux. We tried to do, 3 of them went through pH-metry and impedance, but we didn't have really good correlation. We did endoscopy, and we evaluate them by the GERD health-related quality of life. It's like it's a questionnaire about symptoms of GERD. So this is the basic characteristic. The patient and just a minute, and the result. At TORRE, the mean, we also, of course, measure BMI and total body weight. And this is what we are interested in, the questionnaire about bile reflux. It begins with 30. After 6 months, it reduced to 60. After 12 months, it's a little bit higher, but much less than the 30%. So we suggest that this TORRE may be effective to prevent or to treat bile reflux. So this is humbly, I suggest an algorithm that if patient after one anastomosis gastric bypass has reflux symptoms, again, it's only my center suggestion, we try medical therapy, aggressive anti-acid medication, respond, okay, he had probably mostly acid reflux. If he non-responders, and again, we check if you have suggestive bile reflux symptoms, which are really typical, we try to do pH and impedance manometry and endoscopy. If he doesn't have very suggestive symptoms and negative objective test, we should consider maybe there is other diagnosis. Then we scope the patient. If you have Barrett esophagus, you go immediately to Roux-en-Y gastric bypass because of the risk for cancer. If he has bile reflux, but not Barrett, we can suggest him TORRE. If he complete response, we are happy. No response, he's going to surgery. If you have transient response, we may offer the patient the procedure again. And again, if a patient wants a definitive treatment for his symptoms, we can suggest him to go right away to the definitive treatment of conversion to Roux-en-Y gastric bypass. But still, there are patients that do not want to go through another surgery, and they prefer first to try the reduction of the anastomosis. Since we published this one, we have much more data about that we should collect it again. I'll be happy to have questions, especially from the surgeon in the audience that probably have some issue. Yes, Christine.
I just have a small comment because I just have a small comment because it was always very difficult for me to see endoscopically the bile reflux, but you can make it visible, quantitative, not qualitative, not quantitative, with narrowband imaging. It's absolutely orange. If you look at that,
you can see it. Here.
Yeah, exactly.
Yes.
And I love this very much because this makes it very obvious.
Thank you. Other questions?
I had a couple of patients that were referred to me that still presented severe bile reflux after conversion.
Wow.
What would you recommend? Would you try this anyway with normal size anastomosis? What would
After
you do?
conversion to Roux-en-Y gastric bypass?
With normal size pouch.
It's a difficult question. We also incur to cases like that. We do multidisciplinary consultation. We try to do manometry, pH metry, and I don't know to give you a definitive answer, case by case.
Would you try this approach since you're—
I don't know, because if it's after Roux-en-Y gastric bypass, I think the chance for bile reflux is pretty low, or you think
No,
differently?
they do for sure have bile reflux.
So why not to try that? Yeah.
Exactly. So
Yes,
it-
yes.
what I'm trying to get to is that
Yeah.
it's a non-invasive way
Exactly. Yes.
before trying to revise the whole thing and see what has been done
Yes.
before.
Yes. Agree with you. When
that,
I'm thinking
could be
about
used.
that with you, yeah, it's really simple procedure. Mhm.
Thank
So,
you.
Jigal, yes, I have a question. Yeah, since you wanted me to ask a question. So, have you seen any data which is showing benefits beyond 12 months? Because as I mentioned earlier,
Yeah.
every time we see data of 6 months and 12 months, which is really of no use these days. We look at for 3 years, 5 years, and beyond. And if you narrow down the anastomosis, initially, yes, everything's going to help in the short term. But as I said earlier, you're going completely against the principles of an OAGB or an MGB, whatever it is. So I
Yeah.
think that's the
Just
controversial issue.
yeah. So we keep following up the patient, but in contrary to weight loss, there is no psychological thing in this, less psychological thing in this, like weight regain or weight loss. We have data for 12 months, and I think that you can see the patient is happy again. He can sleep like this and doesn't need to sleep while he's sitting. So I think that the clinical impression is quite robust. In addition, you can see a byproduct of that, they also lose weight. So this is another beneficial thing of the reduction. You need to think about again about the physiology of mini gastric bypass.
Actually, this is my just a short experience. I am a bariatric surgeon, bariatric endoscopist. I do pre-operative bariatric endoscopy. I do my surgery for my patients, and post-operatively also I follow myself. So what is my take is about this? I do mini gastric bypass rather than one anastomosis, which is an anterior anastomosis. This is a posterior anastomosis. And it is a short anastomosis rather than the one anastomosis where you say it is a bigger anastomosis. That is one. The other thing is what I have noticed is I do scintigraphy at 6 months follow-up of mini gastric bypass. And what we have found is most of the bile will be on stomach, not on the esophagus. But off late, and moreover, there is no symptoms at all. Completely. No patients complaint of GERD symptoms post-bariatric surgery. But I do select those patients for only one anastomosis gastric bypass only where there is no preoperative reflux, and moreover, I select below grade 2 lax esophageal hiatus, not more than that. So if those patients are followed up, there is no reflex post-operatively, and we don't get those patients. So patient selection criteria is more important. And obviously, these patients, when you follow up, and of late, we also found that, okay, the scintigraphy is like that. Why can't we do an endoscopy routinely? And we found that at 6 months follow-up, combining with the scintigraphy, we found that non-symptomatic gastroesophageal reflex problems were there, but it was only grade 1. So there is no problem with that. Almost symptomatic GERD is out when you select those patients. That's our take up.
Okay, thank you. Just one notification. The presence of the bile in the stomach, I don't know, it might be cancerogenous in the future, even if the patient is not symptomatic. We don't know it yet. We will see what happened to the patient after one anastomosis bypass in years. And correct me if I'm wrong, I think that the IFSO guidelines for the mini bypass do not recommend specific way of surgery to prevent the gastric bypass. Maybe I'm wrong.
Okay. Okay. Thank you. Thank you very much. So I'll come back to Pishamo and Harris to keep going for the next section. Please, Harris. I don't know if Pishamo is still with us.
Yes, I can hear you. So I
Just
will.
a second, Harris, just a second. We need no sound from Harris.
Can you hear me now?
I can hear you well, Harris.
Just a second.
Yeah.
No, we are not hearing the. Pishamo, please.
Can you-
That's right.
Can you hear me?
Okay,
Okay?
Yes.
I'll
yes.
I'll hand over to Sai.
Now we have
Wonderful.
Now we can.
Wonderful talks, and it's always a fun pleasure to listen to everyone's talks. So congratulations, everyone. So now we're going to switch gears and we're going to shift to a debate format. And for the next debate, the title is Vision is Knowledge and Knowledge is Power. The future of swallowable intragastric balloon technology is dubious. And it's my great pleasure to introduce our moderator for the debate, Dr. Vincent Huberty from Belgium, who's going to be introducing our debaters today.
What's going on here?
So hello, everyone. I will introduce the first speaker while everything is set. So I think it's the pros, and it will be done by Christine Steer, which is the president of the BIWA Association. It will be a great honor. She will speak about the pros of swallowable intragastric balloons. Christine.
Thank you very much. Thank you very much, Sai, that you took the time. I appreciate that incredibly, really. And thank you very much to Harris that he made this possible in that short time. And yeah, I'm the first participant of this debate, and I have the impression it was not wished a debate now, but it is like it is. Debates have to be meant. So the title is Vision is Knowledge and Knowledge is Power. And I am the one who is for the fact that intragastric swallowable balloons, the technology is dubious. And that is why I am the one to paint a somber picture on this topic. And I just can say, keep calm and just swallow it. So there are two types of swallowable balloons. The one is the O-balloon, and the other one is the Allurion. And the O-balloon is filled with gas, while the Allurion, and you saw this those days in the lives, is filled with a fluid. You can see here that the O-balloon only has 250 cc's of nitrogen, while the volume of the Allurion is 550 cc's. And the Allurion is called the complete procedureless balloon. The O-balloon was tested in 2 randomized trials and showed that there is not very much weight loss with that, even if you implant 3 balloons. So I just can say long time no here. So let's see the Allurion, and you saw the Allurion implantation live the day, yesterday, I think. It's just a little capsule that has to be swallowed and then is filled with fluid, and it really goes away or opens by itself and passes through the GI tract. So the thing is that we have to say, and this is my notion, it was to be as simple as a weekly injection of a medication. Is it that really? So if you look at this publication, it shows that there were a little bit of problems with this balloon. And the most important really is small bowel obstruction. But not only that, if you look at that, you see that there has to be in more than 35% assistance to swallow. And Mohit, to be honest, your patient yesterday looked not very happy. Just mention that. But the most important clinical problem is really the bowel obstruction. And this is the reason why I have to say long time, we will not be here very much from the Allurion balloon, because these are the pictures of the small bowel obstructions. You can see here, Angrisani published on this with the topic, the pitfalls of an excessive simplicity, and others did too. Here are more publications on the small bowel obstruction. You can see, and we once had this debate, you remember, in Frankfurt, and I have to say again, don't look up. Don't look up. Why? Because Allurion is now rejected from the French market and it will be rejected in Spain as far as I know. Although I have to say, just keep calm and just swallow it. But this really will be the reason why we'll soon not be hear anything anymore about the Allurion balloon. And here are the side effects again. I don't want to go into detail because I heard we are very late with the time, but it was meant to rock the market as an easy treatment for obesity, but obviously it is not because it has a lot of side effects. And so let me give you the take home for that. Swallowable balloons appear less invasive. The correct position has to be controlled in both Allurion and Obalon. The option of a procedureless balloon appears to be even less invasive and therefore more attractive. It's the Allurion. But one pitfall is really the migration into the small bowel, causing small bowel obstruction. And this is the reason why it was taken off of the French market. And yeah, from Obalon, we haven't heard since long, and you all know that. So there might be more complications that are not reported, but I don't know. But this is my position I had here for the swallowable balloon. Thank you very much.
Thank you, Christine. Okay, so we'll now switch to Mohit, and then we'll have time for questions. Well, I think there's no introduction needed for Mohit. He's a host for this Congress, and he will be for intragastric swallowable balloon. No. Let me appearance. No. Start mirroring. No. No, it doesn't play. No, it's okay. She cannot do it permanently. She cannot do it permanently. Can somebody help me with the presentation, or the person ran away? Can somebody help? Oh, okay. There we have. Okay. So swallow balloons are dead. Long live to it. I don't think so. What Christine is saying is correct. You're already in the campus, but I have a very important disclosure, because that disclosure is very important to make. Around 3 years back, we brought Allurion to India, and we had a company where I was not directly a partner, but associated with me through somebody else, which were a distributor to Allurion. So I was a part of Allurion in the initial journey. And I leave it to you to judge the progress of what I speak in the light of my disclosures. This is my case mix. It's very important to understand that having done close to 2,000 swallow balloons, we are still doing around 30 to 45 of them every month. Now, if there were so many problems, which Christine says, I should have lost my license by now. So the proof of the pudding is here. Not only that I have increased my numbers of swallow balloons, I have increased my number of intragastric balloons because of swallow balloons. I was not doing any intragastric balloon until swallow balloons came. And now, because the patients have gained faith in balloons because of swallow balloons, the number of intragastric balloons have suddenly increased in India. So I think the intragastric balloons owe it to the swallow balloons for bringing back the faith
into intragastric balloons in India. So these are the currently known mechanisms of bariatric surgery, and all of you should know this because now you would be practicing bariatric endoscopy. Oh, am I? No. Okay. So the restrictive effect, the neural stimulation, the patient compliance, rapid transit, dumping effect. Out of these, almost first 4 to 5 effects are there in the Allurion balloon. We have, starting from drugs till the surgery, we have a long gap. And we all know about Ozempic. So I thought that Christine would be talking more about Ozempic and about semaglutide and the mechanism of action, because she believes that that's going to challenge the Allurion balloon. But I feel even that is not going to challenge the Allurion balloon, because if you see here, there is a big gap. Can I have the pointer? There is a big gap between the drugs, the surgery, which will be filled in by the balloon. So if we see here, there is a big gap here. So that's the weight loss by the surgery. And at the top, there are multiple kinds of drugs. But that big gap determines how balloons are going to occupy, and other endobariatric space will occupy that particular gap, because after drugs, we have nothing but surgery. And we all know that there is a dark side to the GLP-1 receptors, including sarcopenia, muscle loss, the Ozempic facies, and several other problems. So when we are talking about that big gap, I just want to ask you a question. The weight loss use of intragastric balloon market suddenly jumped in 2020. And a market which was losing interest because of COVID got suddenly a surge where Allurion grew its business from one country to other by 150 times every year until 2024, when semaglutide was launched. And when semaglutide was launched, we saw a 30% reduction of bariatric surgeries in very matured markets like USA. So why there was a surge of 150% from COVID when Allurion was launched till until 2024? And even now there is a growth of 10 to 15%, not by 150 times, but 10 to 15% because of the semaglutide market. Why do we see? And I'm talking about the global growth. I'm not talking about the growth here. It's because there is a return on investment in this particular model. Now, I'll very briefly explain you why there is a return on investment. There is a return on investment because patients are searching for a non-anatomy altering endoscopic procedure like a balloon, which can be done without surgery, without anesthesia, without endoscopy on an OPD basis, which they can combine with a GLP-1. There are 30% non-responders to GLP-1, and they will choose the swallowable balloon. It's not going to go away instead of intragastric balloon, because you may believe that endoscopy is very necessary for your patients, but patient does not think that way. For them to get an anesthesia, for them to come to the hospital, for them to do a procedure under general anesthesia or maybe under sedation is not easy. They are scared. They always want something which does not involve sedation. These are publications. It's not my publication. This is, the studies have shown with swallowable balloons 10 to 15% of weight loss at 4 to 6 months. At the same time, if you compare it with ESG, the ESGs have required anesthesia, endoscopy, and a lot of downtime, whereas there is no downtime with these balloons. The patients are hesitant about surgery or any invasive procedure like endoscopic sleeve, and they have preferred swallowable balloons due to their ease, safety, and convenience. At the same time, our own internal data suggests that many patients start with swallowable balloons and later opt for bariatric surgery. So this is the data which I'm going to publish, and Professor Edo Arts from Netherlands, he has a similar data. This paper is already, getting revisions. But of 1,808 balloons we have performed, and these are all swallowable balloons, 10% of them have converted to surgery within 1 year. Now imagine 10% of 1,808. These 10% added to my tally and my bariatric surgery volume increased. If I would have not had a swallowable balloon, these patients would have never called me. Never. They would have never called, because they believe I am the one who would either put a scope inside and suture their stomach, or I am the one who would cut their stomach. But now they say, okay, Dr. Bhandari came up with a solution which is non-surgical, no endoscopy, no anesthesia. So let's do it. And these patients have done, and then later on, just like with semaglutide, it has proven to be a gateway for the entry of my patients into my program, and I can retain them over a longer period of time. So there is no debate that these are going to exist. This will be a good gateway. The swallowable balloons have doubled the overall bariatric surgery volume by attracting patients who initially avoided surgeries. Now, if we combine them with weight loss medication, this is the only randomized controlled trial published till date on combination therapy versus simple swallowable balloon. And it says that oral semaglutide and swallowable balloon in combination have demonstrated a much superior weight loss. I'm not going to go into high patient satisfaction rates because Christine reported bowel obstruction, but Christine, I think bowel obstruction never happened with Allurion if the patient selection is good. If you operate patients with incarcerated hernias, multiple C-sections done, incisional hernias, patients who had abdominal tuberculosis, patient who had ileal strictures, it's a poor choice of patients which are already included in. So when we certify you as Allurion specialist, we tell you the contraindications. Even esophageal motility disorders are not good candidates for Allurion balloon. So you need to choose your patient correctly. It's a safe and effective solution. And I would say it's a good gateway to bariatric surgery. We have patients who are ill prepared. And I was talking to Professor Sareen that if I have a patient who wants a duodenal switch, but he's not well prepared for surgery, I need to reduce the size of his liver. I want to bring back his portal pressures to normal. I want to treat his pulmonary artery hypertension. I would never give him a semaglutide. The simple reason being that the patient will have nausea, vomiting, and he's going to leave the drug the second week. Instead, I'm going to put him on a swallow balloon. In 4 months, the balloon passes off. I'll get a patient which is much more prepared for the duodenal switch. So this is not only a gateway for patient retention, but it's a good tool as a bridge for bariatric surgery. So I'm going to say that if you want to perform endoscopic sleeve or a bariatric surgery, these swallowable balloons will be a good bridge, because you can say, now I'm doing something which does not involve anesthesia. It's a OPD procedure. Go get it done and then come back for an endoscopic sleeve finally, or a bariatric surgery later on. So that's the thing. So, you know, they say it's 15 minutes, but in my experience, you have seen, we have done it in 8 minutes today, and with the catheter technique. And you swallow it, it comes out after 4 months. The good thing here is that you have to explain the patient. So here the patient walks in the bariatric lounge, you have to explain him about the procedure. And I think we have gone through the steps. But you see, in our setting, the families have adopted this. So I have loads and loads of family members who come together. All of them are obese. I have a patient consent for this, so don't go into the ethical issues. Enjoy the video. So this is a whole family, 6 members in the family. And why I always show this video, because they all refuse to take my call that, doctor, you're going to do a bariatric surgery. I'm not going to talk to you, but say, no, we have a non-invasive, non-surgical, non-endoscopic, non-anesthesia based solution. Come to us. And they came to us and we did balloons on all of them. And they're also happy. You see, this is all of them getting it done together. And why I have this case, and I'm going to write a case report. Nowadays, journals do not accept the case reports. We converted all these patients to bariatric surgery 6 months after the procedure. Not that they had a complication. Not that they were not satisfied with the weight loss. They had good 12% of total weight loss. But all they said is, now we want something definitive. Now we are not scared of you. You are not here touting the surgery. You are here to give us a solution. So all I'm trying to say is that it means something to me to keep the patient glued into my practice. Again, 1,882 balloons. This is a published data. We have a very good follow-up. You see 14.4% of total weight loss at 6 months, 32.7% of access weight loss at 6 months. Reasonable, I would not say very good, but reasonable amount of type 2 diabetes resolution of 58%, hypertension, dyslipidemia. Now here you see, out of 9 out of these patients, we have some adverse events. So you see the 46.9% patient had nausea, vomiting in the first 48 to 72 hours. And now this is interesting. Nausea and vomiting extending beyond a week is just 10% of our patients. So it's not very common. This is our own article. It's an open access article. You can read it. It's our experience in terms of treating this in patients who are obese and type 2 diabetic. And this is that randomized control trial which me and Manuel conducted. This is published. You can read in the obesity surgery. And you see, fantastic. If you combine this with oral Rybelsus, you have at 4 months good difference of 8.9 kilos between the two groups. So the protocol is put the swallow balloon, start with 3 milligrams oral Rybelsus in the first month, 7 milligram in the second, and 14 milligram in the third, and continue till over a year, and you're going to get good results at 4 months. That was the conclusion. The quality of life, patient had more nausea and vomiting in balloon with semaglutide, but much more better glycemic control than the other patients. So do read this paper. And science is dynamic. GLP-1s are there, but if you combine a non-anatomy altering endoscopic procedure with GLP-1, and take the photograph of this slide, because with Ozempic and semaglutide and tirpacetide rising, a non-anatomy altering endoscopic procedure, which can be done without anesthesia, without surgery, without endoscopy, in combination with GLP-1, will be the future of this space. So thank you very much. I think we are open to questions.
All right, so here is one question.
So, Mohit, I have got a couple of questions to you. One question is, as we know that this balloon disintegrates in a few months, right? It automatically disintegrates.
Yes.
So now, out of your 1,800 patients, how many of them maintained the weight loss at 1 year?
Yes. So out of these
Beyond.
1,800, yes. So more than 50% of them maintained their weight loss. Those who gained the weight back were those who were not on oral medications to maintain the weight loss. So I definitely would say that patients need to be on a chronic medication therapy to maintain their weight. And if you say that who will maintain it without the medication, 50% will maintain it. And that's proven by data, because this balloon is not there just to cause weight loss. It also trains the patient for early satiety. It's a very good trainer for early satiety, and they change their lifestyle.
So 50% of your patients change their complete life?
Yes,
attitude?
absolutely, at 1 year. Absolutely.
That is very unusual.
No,
and my second question is, you said that if you start...
the same data is there with our intragastric balloons also. Yeah.
My second question is, you said that if you start using swallowable balloons, your practice of ESG or maybe bariatric surgery can get enhanced.
Absolutely.
So my question is, this balloon was quite expensive when it was launched in the Indian market.
Yes.
Maybe 3 lakhs, 4 lakhs of rupees.
Yes.
Now you place this balloon, and after 3-4 months, the balloon disintegrates, the patient starts regaining weight, appetite starts increasing. Again, you tell the patient that now you have to do an ESG for another 4 lakhs of rupees. I'm very skeptical. How many of these patients will agree?
Don't be skeptical.
In your situation, it's different, Mohit, because you have a very
my situation is more challenging than you. You live out of Mumbai. I'm from Indore. Believe me, the patients, it's the same thing is happening. The same thing is happening with the drugs. You give patient a drug and he loses weight, and then he wants something of a more permanent. This weight loss is more addictive than marijuana. Weight loss is more addictive than alcohol. It's the most addictive thing on this earth. So patients, when they lose weight, they feel better. And the psychology is, now let me get something more definitive. So we have been able, and the problem here is that what will you do with those patients who would not want to do an endoscopic sleeve or a surgery at the first thought of it? So now I'm here. This is the date today. At this point in time, we have 100 morbidly obese sitting in this room. Now, out of them, 20 would not want ESG or surgery or even a drug. Let's forget. They don't want a drug because they have side effects. They don't want a surgery. It's very invasive. Endoscopic sleeve, they think they have not heard of it, or even if they've heard of it, they think we have to do an anesthesia. Now, those set of patients are many. They would not even call you, because they know that Dr. Medev will do an endoscopic sleeve and I don't want that. Or he will put an intragastric balloon by sedation. I have to go to the hospital. Maybe even a lot of people are afraid of putting an intracath. These are the patients who will never contact you. They will come to me, get a balloon done. And then they will get faith in me because I give them the weight loss. And then when they have to do an ESG, they will come to me. All the patients I have done a balloon, no matter what people said. Dr. Phoebe used to tell me that it will kill your bariatric practice. And I used to think that why? So he said it will kill your reputation because it's a sham procedure. Unfortunately, we have to go into the details and study the psychology of patient behavior and practices which are existent now. Now, patient will not want what we want to offer him. The psychology is that I want this, let me get it. And if you give them a modality which even gives them 5, 8, 10% of total weight loss, they get their diabetes better, their sleep apnea improves, they will have a lot of faith in you. They're not going to go to ex-surgeon in the same town and saying, oh, Dr. Amit put me a swallow balloon, I have gained all my weight. No, because we explain them, we counsel them properly. This is not surgery. This is not endoscopy. This is balloon. That's the limitation.
Mohit, wonderful debate. I have one quick question.
Yeah.
So, like classic teaching is that when you do or bear balloon, when you remove it, you want to wait a little bit before you do ESG to let the stomach heal, right? Like, although recently I did remove one balloon and then did ESG at the same time. So I wonder for a Lurin balloon, what's the closest period between the 4 months when the balloon self-resolves and when you would do an ESG procedure for that patient?
So I think usually for ESG, I would tell you about surgery. So for surgery, we usually wait for 2 to 3 months. I think the same should apply to an endoscopic sleeve, at least 2 to 3 months in our setting. I will not compare the Allurion balloon with Orbera because Orbera causes much more inflammation of the stomach. Allurion is polyurethane. It's very different than the silicone Orbera balloon. But my experience with Allurion, 2 to 3 months.
I know that Harris needs to end the session. And thank you so much, Sai, for being with us. And thank you, Mohit, and everybody else for being part of this. Harris, would you like to say a few words? I hope that now we're going to hear you properly. And Sai, thank you again so much. And I'm very Merry Christmas to you both. Harris, please, just a few words of conclusion.
Yes, sure. Can you hear me okay?
Yes.
Yeah, excellent. Well, firstly, I'd like to thank the organizing committee, Mohit, Christine, Manuel, Silvana, everyone for a very entertaining 61st IBC Symposium. Very provocative. I think I could feel the tension in the air sitting here in Chelsea in London. So the whole idea is to provoke discussion so that we can give the best care for our patients. So I'd like to thank you all for this very wonderful opportunity. It is a huge honor. I'm sorry I couldn't be there in person. And again, thank you, Silvana and Christine and Mohit and Manuel for including IBC in your prestigious first World Congress.
Thank you. Thank you both very much, and a Merry Christmas to you both. Thank you. Thank you very much.
Thank you.
Thank you.
Happy holidays.
Merry Christmas.
So thank you, Harris. Thank you, everybody. At this time, it's my honor to introduce our second keynote speaker, Professor Amit Medev. Dr. Amit Medev, I think, does not require introduction, but I would formally introduce him for the sake of our international audience. Even he does not require any introduction. Dr. Amit Medev is the director of Institute of Gastroenterology at Reliance Health, and he has done pioneering work in